I'm also going to remind everybody that this is not a talk for your personal experience with PXE. So George is not licensed to practice medicine in all the 190 countries in the world, probably France and maybe a few others local to him, but not in the US or in other parts of Europe or Africa or Asia. And so what that means is we'll ask you to keep any personal questions to send to me or Mary in email, and that this is about more general issues so that you can be educated about them. So we're delighted today to have George Leftheriotis with us. Okay.
Yes, you did it. It's good.
Good. And George is at the University Hospital Nice in France, in the Department of Vascular Physiology and the medical unit. We've worked a very long time with George and been delighted to work with him and to hear his discoveries and to collaborate when we can. We are going to invite him now to speak to you about PXE and pyrophosphate, which over the last several years has become very important to our field and to our interest. Okay, take it away, George. Wonderful.
Okay, so hello everybody. This is my first time with the patients out of France. Usually we perform this type of presentation with the French patients, which is a limited number of PXE patients in the world, of course. And so I'm very happy. And also I would like to thank all the organizers, and especially, of course, Sharon, because we know each other for a long time, as you said. I entered the PXE field, let's say 20 years ago, probably, and I will just tell you that, I was involved, in fact, because of another colleague you may heard about, probably, is Ludovic Martin. He's a dermatologist, and he's living in Angers, which was also the place where I used to be for 20 years of my life. And I recently moved to Nice since 2016, not only for work, but also because I am preparing my retiring. And you know that in France, everybody goes on the Riviera for many reasons, and especially because, of course, of the sun. Today it's sunny and windy a little bit, but this is not the most important part of my topics. So I will introduce my talk about the use of oral pyrophosphate, or PPI, as a potential treatment for PXE. And I think we are the first, actually, in the world, to my knowledge, to launch a clinical trial in order to determine if we can use pyrophosphate as a potential treatment. So everything I will show you actually are very preliminary, because we don't have the results right now. It will take some time, and I will give you some information of what is going on, but also how we came to this trial, because you will see that it was not an easy way for it. There were many technical difficulties. So just to show you the situation in France, here you have a map where you have all the centers who are which are identified to take care of PXE patients. Of course, in France, as you know, there are some rare disease centers. They are managed by the Ministry of Health, and we have specific parts, especially in the university hospitals, where the patients are going. And here you have this black parts of France, which is in fact the Pays de la Loire, the Loire Valley. where Ludovic Martin has established what we call actually the National Reference Center for PXE. It's at the University Hospital of Angers, as I already told you. And so there is another center here on the southeast. This is my center, which is a quite recent center because it was created very recently, which is considered as a sub-center. And of course, I take care mostly of PXE. Also, although I have other diseases to take care, like Marfan disease, Ehlers-Danlos, and many others. In France, all the centers actually that we have identified, we are filling a database for this. There is a national database, and the database actually has registered about 500 patients with PXE, which is quite small considering the fact that in France we almost should have, let's say, between 3,000 and 4,000 PXE patients. So that's explained that probably we don't see all the patients as many other parts of the world, and those patients are not really detected as PXE, probably because they are managed outside from the specialized center as we are. So that was the introduction about the situation of PXE in France. Of course, I will not spend a long time about the disease because I think most of you know much better than me what is PXE, especially when you are living with the disease. Just to remind you that it is a rare disease, of course. The exact number of the frequency is not actually very well established. And the disease is characterized by several symptoms. Some of them are very disabling, like, for example, the blindness, which is the major problem of the PXE patient. Also, there are some aesthetic concern, as shown here with the skin folds. But for me, the most important aspect is the arteriopathy. That means that the arterial disease that occur in the late part of the life of the PXE patients. Of course, it has been also reported that renal lithiasis is very frequent in PXE patients. And to go back to the most severe aspects of the disease, except for blindness, we have to report the fact that some of the patients, they have a coronary with angina pectoris, for example, but other, and we recently discovered this, they have vascular hypoplastic arteries. And this is a problem because those patients are not really detected at the earliest time because there is no specific SIG except that they don't have too much classification as usually, but they display stroke, and this is mostly an expression of the disease in the young in the child. This occurs especially in the child. Of course, at the end of the symptoms frequency, you have gastrointestinal bleeding, which remain, of course, and hopefully a very rare situation. So until the 2000, we were not aware about the genes which were responsible for the disease, and it came out with the work of Olivier Le Saux that ABCC6, which is a transporter at the plasma level of the membrane, of the cell's membrane, and especially in the liver cells and the renal cells. But there are other parts in the body where you have this transporter. For example, the salivary glands can display it. And this ABCC6 transporter is, of course, transporting something. And until recently, we had no idea, and we still don't know exactly what the transporter is actually transporting. So it remains a mystery for us, but you will see that there is a connection with the pyrophosphate. And the things is that the transporter is located towards to transport something into the blood. That's the reason for what it is always oriented towards the blood vessels. So it is producing something in the blood that disappear when you have the disease because the gene is not able to provide the transporter at the cell membrane. So that's the situation, and we had a long time without any progress in our knowledge until it came in 2014 a very interesting paper from an American team that you pretty known because this is the team where Koen van de Vettering is actually working. And it came out that they found that in the patients, the PXE patients, and especially the patients with the complete disease, there is a low level of compounds called pyrophosphate. And this was a striking discovery because we knew that pyrophosphate was modulating calcification in the body. And so it was quite the right stuff we wanted to look at. And it was a very important step for all of us. So to make it short, pyrophosphate is a very small molecule. It's a biphosphate. This phosphate has the ability to be separated in phosphate, so it is transformed in phosphate very quickly. I will not describe here the molecular aspect of what's happened, the metabolism of pyrophosphate. It is quite complicated, and I think Koen and others will probably do it better than me. But it is interesting to mention that in PXE patients, the pyrophosphate is lower by about minus 40 to 50% in the blood, in the plasma, which is a very important things to see. So we can, in fact, resume actually the fact that PXE is, of course, a metabolic disease because there is a compound that's supposed to be in the blood that is missing, and this compound is now identified as a pyrophosphate. It seems logical if you want to treat the disease to manipulate the PPI in the blood, and this is what was done, and it is actually done about the therapeutic issues of the disease. And I will try here to summarize the different options that we have in order to restore the physiological level of pyrophosphate. So, of course, you know that there is no gene or cell therapeutics actually available to treat the disease. Sorry for the typos were wrong. I will make the correction. The first possibility is to reduce the degradation of pyrophosphate. I told you that pyrophosphate is living very shortly in the blood, and it is very quickly degraded in phosphate. And phosphate is a pro-calcifying factor. So it's logical to think that if you block some enzymes in the blood that convert pyrophosphate in phosphate, you can increase, in fact, the level of pyrophosphate. And this is the option that Daiichi Sankyo has actually take, and they have developed inhibitors of some enzyme, alkaline phosphatase, and so they are developing actually some studies with this compound. The other option, as you probably know, is to increase the production of pyrophosphate. And in order to increase the production of pyrophosphate, you can use an enzyme which is called ENPP1. This enzyme can do the job to convert a very important compound called ATP, which is the fuel of all cells in the body. So you can convert ATP in the blood into pyrophosphate if you use this enzyme. And this option has been developed by Inozyme, which is a company that has developed INZ 701, and they are actually testing this compound in a rare disease like GACI, which is an extremely severe form in the children, but also actually in PXE. Another possibility is to develop inhibitors of calcification. There are many inhibitors of calcification that are actually used mostly for the chronic renal disease, which is a metabolic disease that calcify the vessels also, but it is not a rare disease. And so inhibitors of calcification are developed, and especially there is one which was initially developed by a startup called Sanifit, and the Sanifit has been recently bought by CLS. And so this company is actually providing studies using SNFF 472, which is probably an interesting way to reduce calcification in PXE. The other way is now another possibility is to, of course, take pyrophosphate from the outside. Of course, the best way is to take it orally because some of the other drugs are used usually by subcutaneous injection, which is less comfortable for someone who will take the drug for the life. And so actually PPI supplementation is a challenge with two options. The first one is to use bisphosphonate, which is an old compound which was used to treat osteoporosis in the past. And the first generation of bisphosphonate called ethidronate is probably a good option because this compound is a stable pyrophosphate compound, and it is better assimilated in the body. But the other option, and this is the one I will now develop for you, is the use of let's say a natural form of pyrophosphate, which is the compound that we have selected for our trial. And now I will tell you a little bit more about this option. Of course, pyrophosphate, as I told you, was known to be an anti-calcifying factor for many, many years since the 50s. We knew that pyrophosphate can be used to reduce calcification. But the problem was at that time that it was said that if you take it orally, all the pyrophosphate is destroyed by the guts enzyme, which are very avid of pyrophosphate. And so almost all the pyrophosphate you absorb in the guts are destroyed very quickly. So you cannot have pyrophosphate in the blood. And in this case, it's a problem if you want to use it as a treatment. And that's the reason for what they prefer to use bisphosphonate, which was a more efficient form of pyrophosphate. But as you know, in research, things are not stable. And someone from Hungary said, why we cannot absorb pyrophosphate even if we take it the appropriate dose, and where this dogma is coming from. And in fact, the dogma was coming from one publication that was done in the 60s, and that was all. After that, everybody thought that pyrophosphate could not be used as a drug or can be assimilated by the body, which was, of course, a wrong option. And András Faradi showed with his team in the publication that if you take by the mouth a certain amount of pyrophosphate, of course a large amount, you can transiently increase the level of pyrophosphate in the blood. And here you see these are normal people. When they take pyrophosphate very quickly, pyrophosphate is increasing, it's doubling. So for some others, it's increasing 6 times more in the blood, showing and proving that you can use pyrophosphate in its natural form for use and to increase pyrophosphate in the body. Oh, the problem is that, as you can see, the effect is not lasting very long, and that's a problem, but we will come back to this question later in the presentation. So that was the first demonstration, and scientific demonstration, that you can use pyrophosphate as probably a way to supplement pyrophosphate in the body of people. So as the step was started and done, lots of studies, of course, most of them coming from the Hungarian group of András Faradi, started to demonstrate that if you use pyrophosphate, I mean, different way of administration, but mainly the oral administration, you can improve and increase the level of pyrophosphate in the body, and especially in the PXE model of the disease, which is the ABCC6 minus mice, which is the model equivalent to the human disease. So they demonstrated with the several studies, I will not develop here, that if you use this pyrophosphate by mouth, in the mice, you can reduce the calcification in the tissue, which is exactly what we want to do by using pyrophosphate. So that at this time, we had lots of element and proof of concept that pyrophosphate could be used as a potential drug to reduce calcification in the PXE patients. So there were, at that time, the last step was to demonstrate that it was possible to use it in human, and especially in the PXE patients. And it took a long time for all of us in the world to set up this type of trial, because as you can imagine, it's a quite costly trial. And also you need a lots of, administrative stuff to do in order to set up this type of trial. And by chance, we were the first one to get the prize, and we launched in 2019 the idea to perform a trial, and the name of the trial is Prophecy, which is much easier to remind that the long title of the trial. And the trial has the objective, as I will show you, to demonstrate that there is a possibility of using pyrophosphate orally in the PXE disease. So this trial is actually sponsored by the French Ministry of Health. So it's academic funding. It's about 700 €. And it is provided by the National Hospital Research Program, and the funding was accepted in 2019, but we only started the study because of the COVID much later, as I will show you. And 2 university hospitals are involved. The University Hospital of Nice, we are the main investigators, and we have also the University Hospital of Angers for part of the enrollment of the patients. So I will just show you quickly the protocol. The protocol is very classical. We have patients here. The patients are randomized in 2 groups. One group will receive and is receiving oral pyrophosphate. It's in a form of gel, which is much more easier to absorb due to large amount of sodium pyrophosphate we use for the study. And this is the laboratory ProNutri who has made the drugs for the study. You cannot buy it actually on the market. It's just designed for the study. And also, there is a control group. Those patients, they take a placebo, and that's it. It looks like exactly the same capsules than the treatment. Actually, we aim to recruit 66 patients which will be treated with pyrophosphate, and 33 patients will receive placebo. So you see that the chance to be treated is higher than to take the placebo, which is something encouraging for the patients. I forgot to tell you that the PXE patients are above 18. It's not designed for the children, and the maximal age limit is 65, because we don't think that above this age there will be a significant improvement in the calcification. Of course, other diseases that provide calcification are not desirable, like, for example, chronic renal insufficiency. So when they enter the trial, they start with lots of examination, and I will show you. I mean, they have radiological estimation of their calcification status in the arteries. They have ophthalmologic examination in order to see angioid streak and so on. They also have dermatologic examination, and they also have quality of life questionnaires, lots of, because it's important for us to know if they feel better. And there is lots of things to do at the entrance of the trial. They also have what we call a PK/PD test, which is a pharmacological test to determine if when they take the pills, I mean the capsules, of course the level of PPI will increase in the patients who take pyrophosphate and not in the placebo. Otherwise, you know, there will be a mixed up of the two conditions, which is not desirable for the statistical analysis. So after 12 months of treatment, the patients are seen again for the last visit. And at this time, we redo all the examination. I mean, the radiological examination for the calcification, the dermatological, ophthalmology, and so on. Everything will be redo at the end of the trial. And it's finished because the trial, the inclusion period for the patients is only 1 year, which is quite a short period of time, but we can discuss this later. So actually, we have included 40 patients in Angers and Nice. About 19 of them have finished the whole 1 year cycle of the study. So they have finished their inclusion period of time, and we need to wait until 21 of them. So we are very close to this part. We'll have done a complete cycle in order to make a preliminary analysis. And if the preliminary analysis is, of course, the statistical analysis is very encouraging, we can continue the trial. But if there is nothing, you know, very much, there is no significant change, we can stop the trial at this time and save time and money, and so the patient will be available for another trial. Actually, we have, of course, some minor adverse effect. Mostly, this is gastric discomfort and diarrhea, and those adverse events are known to occur in the people who take pyrophosphate, and this is the reason for what the safety committee of the trial did not ask us to stop the trial, because it is considered as a tolerable situation. But this is something that we have to keep in mind, that oral pyrophosphate is not actually the perfect drug that we can expect yet. So now I will just talk to you about what were the challenge to design the trial, because it is important to keep it in mind when you want to do such study. The first thing was, of course, to have a reliable dosage for blood PPI. I told you that PPI is decreased in the blood, so we need to be able to dose it. And of course, a reliable readout of the disease progression, which is another challenge that we had to solve. Let's go for the first one, which is the problem of the dosage of pyrophosphate into the blood and especially the plasma. I told you that pyrophosphate has a very short period of life in the blood as heat. I show you that if you take pyrophosphate, it is lasting only 100 of minutes, and after that it disappears, it is transformed in phosphate. And for this reason, you need to have very sensitive methods, plus the fact that pyrophosphate is in a very low amount in the blood, which is at the level of micromolar, which is a unit that show you that it is very small. To compare with phosphate, phosphate is in the range of millimolar, which is 1,000 times higher than the pyrophosphate. So that's the reason for what, until now, it was almost impossible to dose pyrophosphate in the blood, in the plasma. Of course, all the laboratory in the world, they use enzymatic method, which is a very sensitive technique. I will not develop this one here, but the problem with this technique is it is not standardized between the laboratory. That means that if you have a certain level of PPI in one lab, you cannot compare it to another lab because it is varying a lot, and especially it's due to the techniques that you use, for example, the enzymatic kits you use, and that nothing has been standardized about it. There was an advance in our lab using another technology, which is ion chromatography, and ion chromatography can look at PPI directly. So actually, we use both techniques in order to cross-control the technique each other, so that if you have a strange or abnormal result with an enzymatic technique, you can check it with the ion chromatography, and then after that you can redo or reanalyze your samples because something is wrong actually with the technique. This method has been patented, and actually there is a company, a startup, that it is starting to make the dosage for clinical use, not only for research, which is called APIX, and they are supported actually by some funding from the Riviera area. So actually, you can see here that when you dose the pyrophosphate into the PXE blood, you can see that there is a very significant decrease of pyrophosphate comparing the control. And I am very happy to show you a very interesting result of a study that we have recently finished and published last week, where we show that you can actually use the dosage of pyrophosphate to detect PXE disease, which is a very new things, because until now there were no biological tests for PXE, because nothing is different from the normal blood except PPI in PXE. So if you dose PPI, of course, using our methods, it has not been developed with other methods, you have a very high sensitivity, almost 93%, to detect someone with a PXE, and with a very high specificity, of course, if you are under the age of 50 years, which is the usual age at which we detect the disease. And this is very interesting. So the results, if you want to have access to it, have been published in the International Journal of Molecular Science, and it has been recently developed. We are actually on the way to now redo the study using an external cohort, because this result were done with our own cohort actually. But this is very interesting that now we can have some biological way to make the diagnosis. The problem with the pyrophosphate is it is not related to the severity of the disease, and that's a problem because if you want to use a drug, of course, the drug is supposed to reduce the severity of the disease and to make it slower, if you want. And that's the problem because if you make a relationship between the level of pyrophosphate and the age of the patient, as you can see, and especially in male PXE patient, the level of pyrophosphate remains very stable during the life. There is no change. That means that as you get older, there is no significant change as it is in controls. And surprisingly, it is not the same in female PXE patients, and we don't know actually why in female PXE patient, which is absolutely counterintuitive, there is an increase of pyrophosphate in the blood level, although they still have the symptoms. Of course, there is no relationship also between the level of calcification in the lower limbs or in the coronary arteries or the Phenodex score that you probably know. But there is a significant effect, for example, of other drugs, like, for example, of statins. But this has to be investigated more in the future. Which is important is that of course, we cannot use PPI as a biomarker for disease progression, and this is the limitation of the use, and this has been demonstrated already in studies like, for example, recent data from the Van Ackers group in Belgium. So PPI is, of course, responsible for the calcification, but there is no relationship between the severity of the disease and the level of pyrophosphate, which is quite not so unexpected because, for example, in diabetes, you can have a normal blood level at one time, you perform the sampling, but the patient is still a diabetic because at certain part of his life or during the day, the blood glucose is going up or is going up, and explaining that you get the diabetes. Interestingly, there is a score that it is used for the PXE clinicians and also for the patients, which is called the Phenodex score, and this score has been designed by, I think, Sharon, you were a large part of the score, so it has been developed.
100% of the score.
Yes. Oh, I didn't know exactly the percentage, but
yeah, we created it.
Okay, so this score was created by Sharon and other collaborators, and the score is interesting because it's a formula, quite a formula where you can add the score of dermatological disease, I mean symptoms, the eye symptoms, vascular and cardiac, but there is also the gastric intestinal gastric hemorrhage too, I forgot in the slide. And this score is quite interesting because it is increasing with age, which is what we expected. That means that as older you are, and more severe the symptoms are. This is clearly demonstrated in the studies. But there is a problem with the score. I'm sorry for this, Sharon, but we can discuss this later. It is an unweighted score. That means that, for example, for a PXE patient, the sight is probably much more big concern than, for example, the vascular or the skin aspects of the disease. And because also the patients have different phenotype expression of the disease. So in this case, we should have something that take in consideration that, for example, if you have blindness, it's probably much more impacting the life of a patient than to have only some, anesthetic skin folds that can be sometimes corrected by surgery. So that's the question that remains to be done in the future, I think. So it's to design a score that can take in consideration also the level of disability due to the disease. So if we can't use, if those scores are not very representative of what benefit you can have from a treatment, of course, there is one things that can be unanimously selected is the vascular, the calcification, and especially at the vascular level, because we see it at this level very often. And in this case, you can use, of course, CT scan, and those CT scans are able to show you the calcification in the arteries, and so you can make a kind of score using it. It's actually well done, and very popular for the coronary arteries in the general population, so it's a way to use it. But the problem with the CT scan is the fact that the resolution of the technique you use and also the lack of standardization make it a little bit difficult to compare from, let's say, from a site to another one. And for, let's say, a multicentric study, if we expect to do this in the future, it will be a problem that needs to be addressed. There is also another problem is we don't know if the arterial calcification can reverse. That's a very important question. There is actually a very almost nothing in the publication about it, and that's a question that we have to address too. And also, what is the progression slope? How fast the calcification they progress in a PXE patients without treatment. That's something we have to be aware, and we think that 12 months is probably a too short period to detect this, and I will show you why. Now, what is the role of those calcification in the PXE symptoms? That is a good question. Because arterial calcification, presence of calcification in the arteries does not mean that you have a peripheral arterial disease. Of course, it is associated, but it is not linked. That means that we don't know if calcification are responsible for the peripheral arterial disease or are just a kind of biomarker of the presence of the disease. And of course, at the age of 50s, people start to have atherosclerotic calcification, which is a little bit confusing factor if you want to look at the calcification in the arteries. Only one studied the calcification in the arteries using ethidronate as a anti-calcifying drug. This is the study designed by Wilco Spiering in Utrecht. I think you already have some presentation from this group. And so the results were quite disappointing because after 1 year of treatment with ethidronate, of course, the only significant change was observed with the arterial calcium score, but it was a very small change. You see -4%. But there was also an increase in the placebo group, which is quite interesting too. But this is the only result that we have. So 1 year may be too short to demonstrate something, but this is something that we have to keep in mind. But there is another technology that we can probably use for future studies, which is the positron emission tomography, known as a PET, and using a very specific agent, which is 18 sodium fluoride. There have been some attempt to use it in the TEMP trial, but the results were disappointing because we found no change. But we have recent data in another calcifying disease from another group showing very interesting things. And I think this technology should probably be re-examined for the future clinical trial. The problem with this technology is it is very expensive because you need to have a sodium fluoride produced locally by a cyclotron, which is not available in many centers, of course in France, but also in the world. So this is a challenge that we have to discuss for future studies. Now, there is another possibility you may heard about is the T50. T50 is a biological way to examine the propensity of a plasma to calcify. This has been tested mostly in chronic renal disease, but there is a company called Calciscon in Switzerland that provide this, and it looks like that the T50 or calcium calcification propensity score is linked to the severity of the disease, and that's the first data have been published by the Belgium group recently. Also, you can also look at the what we call the PROMs, which are the patient's reported outcome measure, which are scales. It's like, you know, the ESF 36, if you know already. These PROMs are very interesting because they can demonstrate if you have a progression or if you have an improvement on how people, the patients, they feel about their disease and the level, for example, of disability. There are some work going on in Utrecht, in Angers, and in Belgium to set up some scales, especially for the PXE. And at least you can also look at the retinal change. And these aspects are actually developed by a German team. This is Mrs. and Mr. Fau. You may already heard probably about them. They are specially ophthalmologists, and they are probably able to provide us with some very specific analysis of the retina in the near future. So I will conclude my presentation, and I hope you have understand that designing a trial to test a drug in PXE is not a very easy task. Of course, we have designed actually the Prophecy trial, which now start to be a little bit in the past, but we have to now design new trial for the coming drugs that will be tested. And in any case, Prophecy was a kind of a first test to evaluate the possibility, the safety and the efficacy of oral PPI in human using the classical clinical trial design. So for us, it's more a laboratory for the design of the future clinical trials. Prophecy is not very perfect about the clinical design, but this is what we have right now. There are several limitations, as I told you, that need to be in consideration for the future statistical analysis of the result. If we don't see things happen using pyrophosphate, doesn't mean that pyrophosphate will not work. It can mean also that the trial was not properly designed to demonstrate it. This is a very important conclusion that we need to be aware. And also, it's also a way an opportunity to test a new hypothesis, like, for example, we can do in what we call ancillary studies. And there will be an ancillary studies starting very soon using the PET scan technology, as I told you, in order to revisit this question in the Prophecy trial. So I don't want to be and remain modest about the fact that for us, Prophecy is a small step for the patients, of course, but I think it's a very important step for our knowledge on how to design clinical trial in the PXE disease. And to finish with, of course, this work has not been done by myself alone. As you know, we are a group of people working all together. So there are some French clinicians who actually contribute to the PROPHECY trial, dermatologists, ophthalmologists, radiologists, and so on. Of course, there is a scientific team, and it's very important. This team was at the root of the concept of the dosage of pyrophosphate, and I thank them very well because it has been a very important step for all of us. There are also many academic partners, of course, my colleague Ludovic Martin, but some other colleagues in Paris, for example, and abroad, like Olivier Le Sceau in Hawaii, Olivier Van Acker and Wilco Spiering, and also the Pfau family. There are also industrial partners that contribute to the trial, APIX, as I showed you for the dosage, and we are actually engaging some collaboration with other companies, as I told you. And of course, this occurs in the background of networks. And I just want you to excuse me because I forgot PXE International. This slides has been taken from an old one. And of course, PXE International is one of our collaborators, but one of the reasons is that we have some, much more difficulties to do multicentric studies is the fact that we don't have the same, as Sharon told you, we don't have the same, let's say, social security system and so on. So that makes quite impossible to include people outside from France. And also for Europe, it's also difficult because the policies for the clinical trial in Europe but also outside from Europe are very very difficult and usually very with a large constraint that doesn't make easy to include patients from outside from a country. So this is the end of my talk. So if you have any question, I will be happy to try to understand, to answer. And so that's it. Thank you very much again.
Great. Thanks very much, George, for your presentation. It was a very thorough overview. So the floor is open. I want to let people know that I have to stop right at the top of the hour because of another meeting, but we have a few minutes for questions.
I have some question. Can you hear me?
Yeah, perfect.
Sure.
Oh,
Go ahead.
okay, perfect.
Stefan, can you hang on a second and just see if anybody, I know you have some access to George because you're a scientist yourself, but let's see if some of the people with PXE, and then if not, sure.
Oh, no problem.
So anybody have a question?
Look on the chat wall, maybe.
Nothing yet. Lots of times people have trouble with the chat. Donna, you unmuted. Are you having a question?
I just wondered if there was any way to get that, and he may have said it, but I didn't catch it, that pyrophosphate, if that's it, naturally in foods.
Yes, of course. Pyrophosphate is also used in the food industry a lot. It is used for bakery and also for as an additive in many other processed food. But the amount of pyrophosphate you take this way is very small. It's very far from the amount we give to the patients in the form of the capsules. And that's the reason for what it is not effective. Even if you eat lots of cakes, you will have no benefit of it except for the weight. So I strongly suggest that you need to wait a little bit for the future. There will be some, medical form of pyrophosphate if we succeed using pyrophosphate this way. So there is no other way. And the capsules we used are only designed for the study because it's a patented. I mean, pyrophosphate has been patented as a drug. So it's if someone wants to sell it, I think you need to address the question to Sharon and also to András Váradi and also Pete Borst, who are the owner of the patent.
Thank you.
Yes, and I can certainly say more about that. One of our board members actually uses pyrophosphate by the truckload because he makes the sausage for the schools in the US. And he said you would have to eat the trailer tractor truck full of pyrophosphate to get enough.
Yeah.
Richard, I see your hand is up. I think you have to unmute.
My audio button.
There we go. Go ahead, Richard.
I just wanted to say thank you for all the time and energy you put into the trials.
Great.
I thank you very much because it is this is a huge part of my life, to be honest. And also we need to be very patient. And I am close to retire, so I hope that I will see the result. And I think I will live enough long to see probably the last, the best drugs and treatment for all the PXE patients. And but yes, it's quite time. But I am paid for this. This is also my job. So they say I have a nice job.
Thank you. Thanks for thanking Richard. Okay, Stefan, we have 2 minutes. Go ahead.
Okay, yes, so I understand. So this trial, is it in the middle of the trial now? So, or have you beginning?
Oh yes, I forgot to say that we started that yes. No, 2023. We already have enrolled 40 patients.
Okay, and
we are quite half at the level of the trial.
Oh, okay, I understand. And this 40 milligram per kilogram, is it 40 milligram PPI or is it 40 milligram the whole molecule?
The whole molecule.
Okay.
This is the whole molecule, and this dose was decided and was chosen because of the preliminary studies that have been done with András Váradi. So it was based on, let's say, the highest dose we can use. Probably this is something too high, actually, but I think there is lots of work to do about the best dosage, and that's remained a very important question. I agree. But today, yes.
Yes, and have you calculated the efficiency?
You mean the efficiency of what?
Yeah, if
of the drug?
Yes, if you calculate the milligram in blood divided with the intake, what is the efficiency?
It's less than 99%, less than 100%. When you eat 100% of this PPI, only 1% goes in the blood about.
Okay,
which
1%.
Is very small. This is not very, and that's the problem because PPI is, and that's also explained the gastric discomfort that patients they also some of the patients they report. That's a problem.
Yeah, thank you very much, George. Unfortunately, I have to jump to another meeting and use this Zoom. We're very grateful for your work and for your presentation today. This will be in our library, so others can visit it and learn as well.
Thank you very much again, and hope to see you. Bye-bye.